I was thinking, like, if it's... What's that?
We're going to miss the presentation.
That's true, and then we'll be going with. So thanks for coming to Guelph. And so I was just going to introduce some of the team that we've got. So the questions we sort of have tonight would be oncology at OVC, and the question would be what's new. And a lot of what we've got that's new will be thanks to the Pet Trust as well. So I was just going to go over some of the things that the Pet Trust has allowed us to do here at OVC. That's a little bit different than some of you people have already met up with, and others maybe not so much. So first of all, we have for medical oncology, we have Melissa Parsons-Doherty, who's not here tonight. She's actually doing a course in Florida, of course, but she really is honest. She tells me she's working. Danielle Richardson, who's, you know, from internal medicine, works with the medical oncology. Tony Mutzers, who is the person just walking in now with the food, as always, is also a medical oncologist, and myself, Paul Woods. And then we have radiation oncology. We have Valerie Poirier, who is not here tonight because she's actually on maternity leave, but is actually here a few hours a week. We have someone off doing our off-site planning, and she'll be back, though, in a couple of months. And we have surgical oncology. We have Michelle Oblak, who you may know did a Doctor of Veterinary Science here and then did a one-year fellowship at the University of Florida in surgical oncology. And then we have a team that you is not here, is Fernanda Montavani, who is not on a course but is in Costa Rica. So she is a Doctor of Veterinary Science doing a residency here. And we also have, and so she is from Brazil. And we have Jerome Calvalito, who is from France, and he actually is here. And we also have our medical oncology intern, Steve Patton, who is a graduate of OVC and did a master's with Brenda Coomer in biomedical science. And Steve is also here as well. And the good news is, as of just a week ago, that next year Steve will still be here as our first-year resident next year. Jerome thinks he's going to move up the order, and so does Fernanda, because she comes back from Costa Rica. We also have a team that's not here tonight, but you'll be seeing them during the day or hearing them on the phones, talking to you or faxes, would be our oncology technicians. So we've got Mel Brooks, Vicki Heinbecker, and Jerry Higginson. We also have radiation therapists. So we have Kim Stewart and Laura Furness, who are working with our new linear accelerator with onboard imaging. So we have a new device here. We also have a clinical trials coordinator and a tumor banker, and that's Astrid Kuhnens-Hearn. She actually worked doing a tumor bank in the human world in Australia before we got her back here, and that's a position that's supported by the Pet Trust as well. And then we also have a clinical counselor, Bojena, who is a Master of Social Work, and she's here Tuesday, Wednesdays, and Thursdays, and she helps our clients with decision making, so having them say what are their goals and objectives for the different therapies we're offering, and she's a hospital-wide resource, so not just oncology as well. And again, she's supported by the Pet Trust. And for pathobiology, we have Rob Foster here tonight, who's our board-certified pathologist, and he's going to talk with Michelle about some of the things about margins and that. We also, you have Courtney Schott, who's not here tonight, and she's a graduate of OVC who's doing a PhD in pathobiology. So we have all these people, and this is what we typically look like during the day, and so we have all these people. A number of them are supported by the Pet Trust as well as OVC as well. And the big thing, though, is with their transformation of the OVC Health Sciences Center is the Pet Trust has also supported us and helped to create the Animal Cancer Center. And so last winter, not so much shoveling, but a lot more construction going on. And so what we have done with the palm trees here, so we've got the Animal Cancer Center, and who here has been to the Animal Cancer Center? Or more to the point, who has not been to the Animal Cancer Center? Well, if you guys want, we can give you a tour afterwards as well. But basically what we are, there's the small animal clinic. This is College Avenue along here. In front of this palm tree is the old Pathobiology building, and we took 12,000 square feet, repurposed that into an area to do chemotherapy. Also, we have our linear accelerator for radiation with onboard imaging as well. So we can take you down there afterwards as well. And so what we are is a comprehensive cancer center doing diagnostics, so we can do biopsies and advanced imaging, also therapy. So now what we've got with Michelle, we have surgery. With the group I mentioned with medical oncology, Danielle, Tony, and Melissa and I, we've got medical oncology. With Valerie Poirier, we've got chemotherapy. And we have a number of investigational therapies as well. Bojena allows us for counseling, and of course, we're at a veterinary college, so we have education as well. And just walking in the door, even later than Dr. Tony Mutzers, at the back, we have two of our veterinary technicians. We have on the left, well, my left, Jerry Higginson, yay, and then on the right, Melanie Brooks as well, who you may also deal with as well. We have a number of research projects. Some of them are supported by Pet Trust. Some of them have external funding as well. But also, that's where Astrid, our tumor banker and clinical trials coordinator, will be talking. Some of these have some incentives for the clients, such as free blood work and things like that. There's paid up by or immunophenotyping as well. And some of them are still ongoing, waiting to come through regulation to get there as well. The net effect, though, is also, I should mention, we are a part of the NIH in America has a consortium of a number of vet clinics, and we are their only international member. And again, looking at trials, trying to find better ways to treat. They're interested in better ways to treat people, but they're giving us medications that will help us better ways to treat pets. So the idea of some of that would be doing our clinical service to you guys and things like that, and that's our number one goal. But a lot of that, our clients, just like your clients, are saying, what can we do to make things better? So we're trying to take some laboratory findings and take them to the Labrador. And then just my last infomercial, just to mention that coming in May, on May 15th, we do have the Institute for Comparative Cancer Investigations. Brenda Coomer, Biomedical Science, and Tony Mutzers will be running that. And that's more, there will be some clinical things, but it's really presentations by different clinicians and also by researchers on campus of work they're doing in the field of oncology, because the University of Guelph is a medical school. It's a veterinary medical school, and there's a number of other people in nutrition, biochemistry, psychology doing work on cancer as well. And we have Dr. Deb Knapp, who was Tony Mutzer's mentor from Purdue, who's coming to give a talk as well that day. So you can watch for that on our website, and you are invited to come to that as well. So a lot of this is we've got things that are supported by the veterinary college and usual aspects, but I'm just going to put my plug for the Pet Trust, is that what they've done is pledged funding and source for us to allow for a number of the people I mentioned. Also, if you guys want to do the tour of the Animal Cancer Center, it's quite swank. Also nice equipment, as in the linear accelerator with onboard imaging, which allows us to treat radiation therapy, which much more targeted therapy to the cancer and avoiding some of the normal tissues so we get less side effects. And it's also, they have supported us with a number of the projects as well. And now I will hand it over to Rob Foster and Michelle Oblak, who will be talking on tonight. And so I get to lose this. It's on. It's on.
Okay, good evening. Sound okay? Sounds good. I'll be passing this over to Michelle because we'll be doing a tag team session here. We're going to be looking at biopsy technique and particularly some of the practical features of tumor removal. We're going to be looking at margins and staging. And because we want this to be a practical session, if you have questions at any time, just interrupt, ask away. I'm quite happy, and we're quite happy for this to be an open forum. We're used to discussions, and if need be, we can field to the other experts here as well. So just feel free and ask away. What we'll be looking at tonight is, first of all, decision making and arriving at a diagnosis. We'll be looking at approaches to common tumours or neoplasms. We'll be looking at handling of samples, interpreting results, discussion of staging options, and there'll be some opportunity for more questions and also for some case examples. And we have some of the medical oncology people who are going to provide examples as well. So, when you suspect you have a neoplasm, it's important to follow 4 basic rules. And this is the optimal way to approach diagnosis. Now, we know in the practical environment there are cost issues, and clients have certain amounts of money they're prepared to spend. However, what we're going to show you here is what we recommend as the optimal way of approaching it. For some of the neoplasms, unless you approach it right the first time, you may not get a second chance. For others, for many of them, it makes no difference. But there are some instances, and we'll highlight those. So, I've written up here the rules. First of all, know what you're dealing with. And if you know what you're dealing with, you can follow the procedures that will give you optimal treatment. You'll notice that the first 3 rules are the same, and the 4th refers to those. And the best way to approach this initially is with cytology. Now, I kind of say that with some trepidation because I'm not a cytologist as such, but it is a useful tool. You can do it yourself. If you don't feel comfortable, duplicate the sample, send one to the lab, look at one yourself, and get used to looking at them. This is a very quick way of dealing with some of the basic initial questions when dealing with any mass, and particularly with the skin. So, cytology has certain advantages and certain disadvantages, and with any test, you should know what you're going to do with the result. It's a very small sample, and because it's a small sample, your interpretation should be based on that sample. So, one of the first things that cytology does is it separates out what is inflammation and what is neoplasia for the majority of circumstances. And there's no point in doing a 3 centimetre margin kind of excision if it doesn't require it. It works very well for differentiating several neoplastic groups, particularly in skin, epithelial, mesenchymal, or round cell. And it's very accurate at identifying mast cells, which can be quite a nuisance. So know your limitations, and the diagnosis is then confirmed with histology. So if you have your clients prepared for the fact that this is an initial test, it will allow you to indicate an approach. Let me show you an example. This was a skin mass from a dog, and this mass was very well circumscribed, and it was this is the actual slide, photograph of the actual slide that was examined at histology. And you can see that this is very well circumscribed, this lesion. And the person who removed this did what we call a marginal excision and just took the minimum amount of tissue to get it out. This would work with an epithelial tumour, but this is not an epithelial tumour. And I've used this here to demonstrate that the centre of this shelled out, and that's quite often a history. It shells out, so you think you've got it all. But in fact, that's not the way it works. This happens to be a soft tissue sarcoma, spindle cell tumour of soft tissue, whatever particular name you want to give it. And as such, this required then another surgery to completely remove it, because neoplastic tissue is at the edge. Now, I'm going to try and do something which, caution should say not to, but we've moved on to the digital world here. And this is what the veterinary students now do in terms of histology. They don't use microscopes. We use digital slides. And so with this, you can very quickly move and up into here, zoom in to show that these soft tissue sarcomas are very infiltrative, and this one is at this particular margin. So I'll be using this as we go through to illustrate certain points, and this is what the veterinary students deal with now. It's all computers and digital. So, over to Michelle.
Thank you. I'm just going to pin this. So I think, as Dr. Foster's kind of illustrated, I think cytology is an excellent place to start. Sometimes cytology is all we need. And so there's always this debate of when or how or should I biopsy versus do I just take it off based on cytology alone. And the biggest thing, as we have already kind of discussed, is the limitations of cytology. So it depends on a lot of factors. One of the really nice benefits of cytology and not doing a biopsy is that if you have your answer, you can go to your definitive surgery. So no middle step. So, one of the frustrating things, or one of the negatives for sure about doing a biopsy, more cost, more time. You have to biopsy, and then you submit it, and then you wait. The clients are trying to understand the difference between what's a biopsy and what's not. Even in explaining, okay, well, here's the process of what we're doing, sometimes it's like, well, I just want it off. I don't want to deal with all of these things in between. I just want it gone. And so that can certainly be something that's important to consider as part of your decision-making process. On the flip side of that, though, in certain situations, having a definitive diagnosis is going to significantly change what your plan is. And I think one of the best examples of that is sarcomas. So especially things like vaccine-associated sarcomas, peripheral limb sarcomas, the best chance that you're going to have to treat those definitively and be successful is going to be if you have a diagnosis ahead of time. Grading that diagnosis can also be quite helpful. Sarcomas can be a little bit challenging depending on the size and where your biopsy samples are coming from, but it really can make a huge difference to your plan. And so it's really important to keep that in mind. What's the ultimate goal and what's the ultimate plan? As you deal with on a daily basis, even more than we do, clients just want it off. They don't really think they care what it is until you call them to tell them that it was a dirty margin and they have to do more. And then suddenly it's a whole other ballgame. And so, really trying to take that step back and make sure they understand is going to make a really big difference. Perfect. So you really always want to consider your surgical approach when you're considering a biopsy. And by that, I mean, what is your definitive surgical approach? So not necessarily your surgical approach for your biopsy, usually pretty straightforward. But if you're going to treat, so if you're going to do definitive therapy, how are you going to be approaching this tumor? Honestly, if you don't know the answer to that, maybe not biopsy it. So if you're considering that referral is an option, it's actually, we would much prefer to receive the case prior to a definitive diagnosis if you're not sure, but the owners are interested in pursuing more aggressive therapy. And the reason for that is that my surgical approach can be significantly affected if a biopsy is done in a location that's different. And I'll give you an example of that than what we would do surgically. Because if we're going to biopsy, we always want to think about, as I said, taking out the tract. So that is one of the main disadvantages of biopsying, is if you do a biopsy, you've now disrupted a fairly large margin of tissue in an area. And so if you leave that margin of tissue, even if you think you've done a clean excision and you get normal margins back, if you haven't taken that biopsy tract, you've left tumor cells behind. And so all of that is negated by the fact that there's tumor cells left behind. So don't ever be afraid to say to a client, I'm not sure what this is, but I'm not sure how we're going to deal with it, or this isn't something that I'm comfortable dealing with in practice, so we should consider this is very likely a tumor. We should consider referring you sooner. No problem at all. And honestly, in a lot of cases, we prefer that because it does really affect the approach. Really important to think about complications as well. So things like thyroid tumors, hemangiosarcomas, those are not uncomplicated procedures in terms of a biopsy. Seems really easy. It's a small mass on the neck. You can move it around. You're not really thinking it's going to be a big deal. we've transfused dogs just from doing cytology on thyroid tumors. So, it's not, these procedures aren't uncomplicated, and sometimes there's things you just don't want to deal with in practice. I don't want to deal with them here either, so I really completely understand that. And so, don't be afraid to kind of say, you know what, this is more than what I'm comfortable with. And also to consider, what's it going to tell us and what's it going to affect. So when not to biopsy, we've kind of covered this, but essentially if you're not sure how to treat it, it's probably a good idea to really consider whether or not you should biopsy it. If it's going to affect whether or not the owners are willing to pursue something, or you're not sure whether or not you should be sending it, it's totally, I'm not saying don't biopsy, but I'm saying don't feel obliged to biopsy. Sometimes we don't need to. So a mast cell tumor, I can't remember the last time I biopsied a mast cell tumor. It's a real pain. They don't heal. They bleed. They basically have to sit as open wounds until you can do a definitive surgery. And for me, most of the time, actually, mast cell tumors, I can get a fairly good sense based on looking at the tumor, what grade it's probably going to be based on how it's behaving, where it's located, is it cutaneous versus subcutaneous? And so I'm more comfortable making my decision plan based on that. If it's in a location that I'm concerned that may be a higher grade tumor, then I'll consider biopsy. But generally for me, it's like biopsy it, wait till the histo comes back, and do surgery as quick as possible because I don't want to deal with that in between. And so, don't be afraid. If it's not going to change the plan and the grade isn't necessarily going to change your plan, so those two things together, then it's very reasonable to consider skipping the step. Definitely, sorry, go ahead.
Are you saying that you're diagnosing a mast cell tumor by looking at
cytology? Okay. Yes,
cytology
combined with,
okay.
Yes.
I knew you were good.
Not that
good. All right, that's good. But when you get, I've had cytology reports come back and say, sorry, we can't grade this one.
Sure. And you shouldn't be grading it on cytology alone. So a grade is a histologic diagnosis, absolutely. And so for me, a lot of it depends on what my treatment plan is. Most cutaneous mast cell tumors are in locations where, quite honestly, you can get a pretty decent margin regardless of what grade it is. Most cutaneous mast cell tumors are not high grade, and most cutaneous mast cell tumors, if they are high grade, you're going to know it because there's other characteristics. So the dog's having potentially central signs you're concerned about. They're the ones that are crazy shrinking and growing back and forth. There's a lot of bruising. You touch it, and it's, there's kind of other signs that suggest that they're more aggressive. And there's also been a little bit of a shift away from or a change in how we deal with mast cell tumors surgically. And so that's another kind of important point is I can't think of the last time I did a 3 centimeter margin on a mast cell tumor. There's really been a shift, and I'll talk about it a little bit, but in general now the thought is probably taking proportional margins on mast cell tumors is appropriate because a lot of them are a lot less aggressive than we think, and a lot of them don't come back. So to me, proportional margin would be if I have a 1 centimeter mast cell tumor, then I'm going to take a 1 centimeter margin. And that's going to include a deep fascial plane, and we'll get into that as well. So that's kind of the key. So probably a lot of what you're doing in practice, I know what I was doing in practice was excisional biopsies. So little mass, you find it at the same time as a dental. Hopefully you do cytology and figure out it's probably nothing. So, the majority of cutaneous masses that we're coming across are these benign adenomas. They're benign things, and we're not that worried about them. And so in those cases, you're probably thinking more excisional biopsy, so taking a margin or a minimal margin, but taking the whole tumor, versus your incisional biopsies. And so for incisional biopsies, one of the nice things, and quite honestly, we often don't do it here, but it's more of a logistics issue, but you can often do them under just sedation and local. If you're doing them under local, make sure that your local is not going to affect your sample. And so you don't want to just put local through the whole tumor, which I've seen done surprisingly number of times. You really want to put local you're kind of thinking ring block, so put local in that area, and then you can do your incision. Generally, heavy sedation, dexmedetomidine, very rarely general anesthesia, but depending on what you're doing, you can, again, usually fairly superficial mass is fairly easy to get to. There's going to be some variations in that. And then, depending on where the location of the mass is, how big the mass is, you might vary your preference for how you prefer to take your biopsy sample. So I tend to be a big fan of just doing a wedge. Some people really like to use the keys punch, so the punch biopsy. For me, I like the wedge because I can usually close it, whereas I find sometimes when you end up with that circular hole, you're trying to figure out how to put a suture in it so it'll stop bleeding. And so I find it just a little bit easier sometimes if I make the shape to what I'm going to be able to close. Some of you may have true cut biopsy needles in your practice. If you do, I tend to save those for like the really big tumors where I can take, quite a few samples in multiple directions. They're nice because it's a really, really tiny little incision. So you can get a bunch of different samples that way, but in general I don't find them as useful because I'm always worried. It's such a small piece. I feel a lot more comfortable that I can get a bigger piece. The most important thing though is a lot of times you're probably going to be doing these for soft tissue sarcomas, and they do have a pseudocapsule, and sometimes they can be surprisingly deep. So make sure you're getting a sample of what you think is truly tumor. Don't just take a superficial piece, because most of the time what ends up happening, or many times what ends up happening, is you get a nice piece of skin and subcu tissue and maybe a little bit of pseudocapsule, but a lot of times if you're not right down deep in there, then you won't actually get a piece of your tumor. And that can be a little bit frustrating, because then you're calling the owner and saying, wow, we didn't really get an answer, we need to do it again, and things like that. So one of the most important things, as I said, is make sure you understand what your surgical plan is before you're doing your biopsy. And I think this is a really good example. So ignoring the portion inside the mouth, because I couldn't get a good picture, I couldn't find a good picture, but think about a tumor, and you've all seen them, where you have a dog come in with a huge swelling on its jaw, and there's not really much in the mouth. There's maybe a tiny little bump, but the majority of the tumor is deep to the skin, so it's a bone tumor probably, or an all tumor, but most of the tissue or the swelling portion is coming from underneath that jaw. There's such a huge inclination or drive to want to biopsy it right here, because this is where you can feel it, it's really easy to get to, you don't have to go in the dog's mouth, it seems cleaner. The challenge is for me, is anything that's a bony tumor in the mandible, my surgical approach is going to be ventral midline, but I'm not taking any skin, because these tumors are well circumscribed usually within the bone, and so I'm using my plane is actually going to be either periosteum or some of the muscle kind of in that area. And so as soon as I biopsy this way, I've now disrupted my really nice contained tumor, and I've seeded this whole area with tumor. And so it's really important in this case that we actually biopsy through the mouth, because through the mouth I'm going to be taking that portion of tissue with the tumor. And so it's just another one of those scenarios. Think about it before you do it. Make sure you know what the plan would be. I've had a couple of dentists now even that have gone this way, and then suddenly you're having to resect a really wide tract around that area, and instead of it being a procedure that's actually surprisingly cosmetic because you're not taking any skin, and I actually don't even clip these guys a lot of the time, you're now having to do a big resection and things. So just the clip under here rather than a big wide clip and a big resection, and sometimes you're having to reconstruct with flaps and things like that. So it makes it a much different surgery, and actually increases your risk of local recurrence even when you think you have a clean margin, because you've disrupted things a lot more. So just something to think about that way. What about bone lesions? I know all of us struggle with this. We get these dogs that come in and they have these suspected or suspicious lytic bone lesions. And there's this desire to biopsy them to try and get an answer. I think for me, in general, we know that at least 80%, and my personal experience is here at least, is probably getting up into the 90s and higher percent of these lytic bone lesions are going to be primary bone tumors. And so if that's the case, is a diagnosis specific to what kind of primary bone tumor, is that going to change what I do? Probably not. So most of the time amputation, potentially some limb-sparing options, potentially limb-sparing options that are surgical or with radiation. So those are all of our options, but is that going to change what I do? Probably not. Many of you may have seen some of the literature on doing aspirates of bone. Usually with these lytic bone lesions, you can get a really nice aspirate, especially if you do it ultrasound guided. And so I'd really encourage you to take a step back and put down the bone biopsy. Because honestly, it really, again, if we make an incision through the skin, and we're planning on radiating, and now we've created a tumor tract, it makes it a little bit harder. Sometimes with a bone biopsy, if we're considering stereotactic radiosurgery or some other limb-sparing techniques, if we do a bone biopsy, we create a stress riser, and we're actually increasing risk of fracture, so we don't want to do them in those cases either. And so Definitely encourage you, if you're wanting to get more information, don't do a cytology, or again, don't be afraid to send them, and we can do all of that for you. You know, there's nothing more scary than hearing that creaking sound as you're going through the cortex of the bone and hoping you're not going to break it. And so don't be afraid in those cases. Send us the radiographs. You know, what do you think? Are you concerned? But in the majority of cases, you are certainly, you know, those are cases where we really isn't many indications to do bone biopsies, and we get a fair number of them sent to us kind of as a bone biopsy or for a bone biopsy, but typically we're not needing to do those. All right, so what about excisional biopsies? So we talked about incisional, so we're leaving it in place, we're just taking a piece of it, getting an answer, and then going back to surgery. But what about in these cases where, you know, we think it's probably a really benign, it seems like a little benign cutaneous nodule, you know, it's a lipoma, we're in the abdomen and we see a spleen with a mass on it. All of those cases, we're going to try and do a more definitive surgery as part of our surgical excision. In a situation like a cutaneous mass, if you're doing an excisional biopsy, I hope you've done cytology. We're going to keep going back to that because you wouldn't believe how many times people just take things off. If you do, as the example of what Dr. Foster said, soft tissue sarcoma, if we don't know what it is ahead of time when we do a marginal excision, we have to recut that. So if you just scoop it out, which soft tissue sarcomas love to, they're so easy to just like get in there and just scoop them out. And that's like my worst nightmare. Just don't do it. The best thing you can do with those types of cases is if you think you have a definitive answer, but you're not sure, but this is kind of how you want, you know, it's small enough that you're like, well, you know, if we needed to, we could recut it. It's in a good spot. We're not that worried. I'm 99% sure it's benign. Take a very narrow margin and try and disrupt as little as possible. So a benign tumor, if you take even a ½ centimeter or less, you don't need to take a deep margin. Just really take it very marginally. If that's a benign tumor, that's plenty. So if it's benign, it's not going to come back. If it's malignant, we're going to need to do more, but probably at that point, if you haven't disrupted too much, then surgery, a definitive surgical option is much easier than if, you know, we start doing kind of this halfway in between. So many times it's like, well, I took like a centimeter or a centimeter and a half because I wasn't sure. So now we're kind of in that gray zone of we've lost enough tissue, it's a little bit harder to then, because now if we're going to take 3 centimeters, we're going 3 centimeters beyond that 1.5 centimeters. So then we're starting to do a much bigger surgery and more morbidity. And again, the first time I cut, I can be pretty happy that if I have a clean margin, the chances of local recurrence are fairly low. As soon as that plane's been disrupted, as soon as it's been cut before, even as soon as it's been biopsied and there's been any sort of hematoma or seroma or anything like that, suddenly those neoplastic cells that should have been contained are doing whatever they want, and everything's breaking the rules. So we no longer have as much of an opportunity to say, yes, everything's contained, we're removing it without touching it. So, you know, really try and keep those things in mind. Lipomas, all of those kinds of things, those are all going to be excisional biopsies, but you're going to get your answer, and, you know, lipomas, maybe you're going to submit it, maybe you're not. But otherwise, you know, it's really good to at least have an answer, and to go along with that, and Dr. Foster will talk about it, you know, it's really important to get histo on these samples. I know it's always a challenge. You're kind of selling people and taking it off, and then it's like, and now you want to do this, and then you don't have an answer for that, and you know, people do have a hard time, and there's not every client is going to be amenable. In general, I can tell you here, and it's easy for us to say, but we will not take something off without submitting it. So that is, you know, if you have any clients that are ever coming to see us, that's a non-negotiable aspect of our quotes. It's something that's built in, and it's not an option. I will say the caveat is maybe a lipoma. If I cut through the middle of a lipoma and it floats in the formalin and I'm confident there's no core, then I will kind of think about that one because I don't know that that's necessarily the best utility. But aside from those, you know, the majority of the time those samples are getting evaluated. All right. So, you know, going through all of this and talking about all of this, the ultimate question often is, so what can we cut? What should we cut? Everyone's going to be different. Everyone's going to have their own comfort levels. What I'll tell you is about a lot of the cases that we end up kind of seeing for second opinions or as kind of secondary cases and some of the challenges that we face with those. I think in practice, the majority of what you're going to see on a regular basis are going to be lipomas and cutaneous masses. Most of those cutaneous masses are going to be these benign warts, papillomas, and things like that. You're going to then kind of get into your histiocytomas, your mast cells, and things from there. And I think all of those things in the majority of cases very, very reasonable, very straightforward, and pretty amenable to being done somewhere where there's not advanced imaging, staging's not being done. You know, a lot of those things we can kind of make up for if it does turn out we get into trouble or we find something that we're not expecting. So those cases in the majority of times, very, very reasonable, easy things to do in practice. You know, I think a lot of times you're going to be dealing with compartmental things. So you're in an abdomen taking out a spleen, or you're in an abdomen maybe taking out a liver, depending on how brave you're feeling. Hopefully not the whole thing. You're doing, you know, you maybe go after a mass on the neck and it turns out to be a thyroid. You know, a lot of those things, very reasonable, very straightforward things to do in practice. The challenge becomes in the situations where often it's the owner is really pushing, they really want it off, and you're kind of like, well, you know, I guess I can take it off, and then suddenly you do, but you're doing a marginal excision, or you're doing a little more than a marginal excision, and then the owner's coming back and saying, oh, well, there's a dirty margin, well, I want to go to Guelph. And then it's like, oh, crap, now what? And so, you know, I really think it's important. Some of the situations I think it's really important to counsel and think about ahead of time are going to be any of those subcutaneous masses. So aside from a lipoma, subcutaneous masses sometimes can be really challenging to cut without image guidance. So a lot of times you're feeling things, you're kind of digging around, you're like, okay, where is this? Trying to get a good sense of what's going on. But it can often be very hard to decide, okay, what's my fascial plane? How am I going to be dealing with this kind of mass? Am I going to biopsy it? What am I dealing with? How big do I need to go? All of those things, a lot of times, we're going to be doing based on image guidance. And so to ask you to do that in practice by feel is really unfair. And so it's kind of putting you in an awful situation where you're not able to have the full information. Then you're asked to do a surgery, which you don't have all the information for. So then, big surprise that we don't have a clean margin in these cases. That's not unexpected. It's not a matter of your ability to actually do the surgery as much as it's the information that we have going in. And so, you know, I really discourage people from doing any sort of limb surgeries. If you can at all, get out of it. Just get out of it, because most of the cases that we have coming in, unless the tumor is, you know, probably more than 50% circumference of the leg, with a lot of these low-grade tumors, even some of these mast cell tumors, we can get a clean margin and not need adjunctive therapy. So adjunctive being radiation, not necessarily chemo, but depends on what it is and what we're dealing with. But the majority of soft tissue sarcomas below the elbows and below the knees are going to be low-grade. The problem is as soon as that gets cut, and cut with a dirty margin, we lose that window. There's no extra skin. We've maybe disrupted the fascia, or the fascia is not disrupted, but there's nothing left to close. And so, you know, the majority of those cases, we can get a clean margin on the first cut, but only the first cut. And if I can't cut it clean on the first cut, I'm in the same boat. But at least we've had the opportunity to take it as wide as we possibly can. A lot of those tumors actually don't need 3-centimeter margins. So the general rule of 3-centimeter margins in a fascial plane for sarcomas doesn't necessarily always apply to those tumors. And so that's another thing to kind of be aware of, is we're not necessarily always going as big with those. The other area that can always be a bit of a challenge is these sub-Q mast cell tumors. They can be a little bit hard to even see discretely where they are. You kind of get in there and you're not really sure, and where's the fascial plane and what are we dealing with? And so we, again, often rely on some sort of image guidance, or at least sort of experience of where our fascial planes are and what we expect for that as part of it. And so those are really important. Probably above all, the ones that are really hard, unfortunately we don't see very often anymore, are going to be our vaccine-associated sarcomas. So in general, those are very, very nasty tumors, and they often are caught fairly quickly because they're in an area where they're fairly easy to feel. The challenge is, though, is they also are often excised, just as kind of a marginal excision or a sort of in-between excision, and those can be very, very challenging if we get this, you know, 1 centimeter, or I scooped it out, or things like that, because suddenly we're dealing with a fairly large scar. We're having to create our margins around that scar. And in theory, we're talking about 5-centimeter margins and 2 fascial planes for those, because they're aggressive tumors. That's half a cat to begin with if it's a small tumor. And so, you know, we're getting into then, okay, now what are our other options? And so that's another area where if it's in kind of a classic location, honestly, a lot of tumors in cats, we just don't see tumors in cats all that often, other than, you know, your occasional mast cell tumor. And typically, any sort of subcutaneous tumor in a cat, I generally take a step back and sort of really think about, okay, what could this be, and what are the consequences if I do anything before imaging or getting more information. So just something to keep in mind. So what's a fascial plane? Essentially, a fascial plane is a border or a boundary which tumor cells should not be able to infiltrate through. And so that does not include fat. It does not include areolar tissue. It doesn't include anything that isn't going to actually stop those tumor cells from going through. And that's really, really important to keep in mind. So a lot of people are really comfortable taking a wide lateral margin. We get tons of cases where it's got a beautiful, clean lateral margin, no sign of tumor cells anywhere. And then there's evidence of tumor cells at that deep margin. And the reason for that is I think a lot of people have a little bit more trouble kind of dealing with this whole idea of a fascial plane. And so when we talk about tumor excisions, usually we're going with those metric margins laterally, but a fascial plane doesn't need to be that deep, and Dr. Foster will get into that a little bit more. But really, that fascial plane should be a boundary, even if we're talking about millimeters or less. But the key with that is that the tumor can't be adhered to that fascia. So as soon as you have a tumor that's adhered to your fascial plane, that means the tumor is probably invading into that fascia. That's no longer a boundary. And so a fascial plane should be a mobile, it should be that mobile layer beneath. And so if you can move your tumor over top, then that's going to be a nice fascial plane underneath. Sometimes you can get away with a paniculus for a mast cell tumor, but not unless you're really happy that it's not like that wispy, you know, sometimes you kind of see the like wispy, stringy paniculus. To me, that is not a nice border. This should be like to the naked eye. You look at it and you see a shiny surface and you're like, yes, I cut through that and I feel like there is something in between. It's not necessarily going to be that substantial in terms of the thickness, but you really want to feel like you're truly going through something beneath your tumor, and that should provide a boundary. So practically, that's going to be fascia in the majority of cases. That can also be muscle. So sometimes, especially on some of the limbs where you've got multiple muscle bellies kind of coalescing, you can't really just take fascia and be happy with it. So you sometimes have to take a little bit more so that you're happy there's a continuous layer beneath your tumor. Sometimes that's bone. So in a lot of cases for our oral tumors, if you have a squamous cell carcinoma or something on the cheek or in the lateral aspect, the only thing that we can remove that's going to take us to a clean margin is bone. And so we quite frequently will use bone as part of that fascial plane. And so that's going to be another kind of important thing. But it needs to be a true barrier. It needs to be an actual physical barrier to prevent those tumor cells from going deep. I think this is you.
Okay, I just want to show you what a fascial plane can look like. And this is one of these whole mount photographs again. And this particular tumour, and all the ones I've shown you are not ones that have come through the service here. These are what regular practice veterinarians have sent in. So on this particular example, and again, we're going to try and get into the realms of the modern digital technology. So here's our skin layer at the top, and here's our mass. And this mass would not have felt very discrete. It would not have been just a regular solid like basal cell type of tumour or follicular tumour. But you can see that this sample here, this is the whole sample that was processed. And here we have skin. Epidermis is the little blue line on the top. And we can get down and have a look. And then we have dermis here, and these are hair follicles. Now, the fat beneath is the white space, the empty space. Down here at the edge is a fascial plane. We have run away. Okay. Right here. And that's what, as a pathologist, I will comment about. And it's now standard procedure for all tumours. If there is evidence of a fascial plane, then what that tumour is doing with the fascial plane will be reported. If there's no fascial plane, and there should be, then that will be reported also. There was no fascial plane. So that you know that you've got a neoplasm where you don't have an appropriate boundary at the bottom. Now, this layer of connective tissue here is very thin, about 0.5 millimetre, but you would still be able to see that as a definite boundary. If there's muscle underneath, and in some parts of the body, the fascial plane is actually the epimysium. It's the thick covering over the muscle. This particular tumour here is a soft tissue sarcoma. And this illustrates that sometimes the best time to get it is the first time. So you know what you're dealing with. It's not a discrete tumour. And this one has tentacles going everywhere. And this is just like the sarcomas in cats. They have these little tentacles which go everywhere. And this one here has actually breached that barrier. This tells you that it is not behaving the way it should. And in this case, it's right down at the bottom. Even though the person thought they were getting a good margin, about 1 centimetre, it's got tentacles that are extending along here, where the hand is, right out to there, and it's gone right through that fascial plane, and it's down at the bottom margin, right there. These are ones where if you get a report like that, and Michelle will, I'm sure, confirm, these are best to cut right away. Because as soon as you let granulation tissue grow in there, it just messes up our ability, pathology ability, to determine if you've got sufficient. So granulation tissue, seromas, look just like the cells in these soft tissue sarcomas. Okay, so we're going to talk more about margins, and I'm going to let Michelle here show the surgical perspective. Question there?
What about, when you talk about rolling and inking, are you going to talk about
yes,
any benefit?
We'll talk about inking margins.
Thank you. I think you're up next, like just one slide. So from my perspective, I'll kind of just give you some quick thoughts on margins. A few really important things from a surgeon's perspective. Think about what your surgery was, and whoever's done the surgery really should be doing the inking. You know, I think there's a tendency, it's really easy to kind of just throw it to the side and then someone else ends up inking it for you, or they're asking you over the phone because you forgot. But really, the point of inking is to identify the margins that you've taken and also to identify what you're worried about. So if you had a surgery and you were really, really happy with 90% of it, but you were like, that one lateral margin, just, I felt like when I cut that margin, it seemed a little closer, or, you know, I was concerned that that just didn't seem quite right, then try and identify that and communicate with your pathologist about that. You know, Dr. Foster's going to get into it, but amazingly, for us, I think we get into this perception or this thought that if we get a clean margin on our sample, then it's never coming back. We're definitely fine, no issues, there was definitely no tumor cells around any of the margins. You're only going to get 5 margins. So think about your whole tumor, think about things from a microscopic level. We're only going to get tiny samples of certain points of our margins. And so if you get lucky and that spot you're concerned about is considered in that cross-section of your margin, great. Hopefully it'll be evaluated. There's a very reasonable chance though it will get missed, or it won't get looked at, not even missed, but just missed by virtue of we can't look at every single corner of every sample. Just stick a suture on it, make sure you somehow identify it if you're concerned. Submit the whole sample. Dr. Foster is going to talk a little bit about how to do that in a way that will make life easier. I know it's always hard. You don't have a bucket of formalin often in practice. You know, there's this inclination to just take a piece of the middle, okay, we'll get a diagnosis, but so many times we get these samples, or we get these histo reports of, okay, well, it's a mast cell, and it's maybe a grade 2 based on the chunk that we have, or whatever they call it. And then what about the margins? So you've done this beautiful surgery, you've taken these nice wide margins, you've taken a fascial plane. We have no evidence of any of that. And now what do we do about it? Because we don't know for sure what went on, you know, how comfortable were you with those margins, was there any chance that there was neoplastic cells at those margins? So as much as it can be challenging, it is a really good idea to submit the whole tumor. Don't just submit a piece of it. And then, like I said, make sure you provide specific comments and suggestions on what you saw, what you were worried about. If you already previously did a biopsy, the more information you provide, the more information you're going to get out of it. If you don't ask the questions, then they don't know to provide you with those answers. You might get some of them, but there's a chance that you're not going to get answers. So, really get to know your pathologist and really don't be afraid to ask them those specific questions.
Okay, so from a pathologist perspective, margins and tissue sampling. We are here to provide you with the best information we can, and we need the clinical information, and we need that to be as accurate as you possibly can. We were talking about oral tumours before. A lot of people hand the submission form off to a technologist and say, fill in the form and send it off. We rely very much on location for our diagnosis. There is a world of difference between something that's in the skin and something that's in the mouth. So saying it's on the lip, saying it's on the jaw, you have to be specific for us to give you the best diagnosis and prognosis. And be as accurate as you can. When it comes to margins, margins are things that you as the surgeon should tell us where you want us to concentrate our sampling. If you ink a margin, then we know that that is exactly the area that you want us to look at. Tissue, once it is fixed, changes. Fixation actually causes distortion in tissue. It causes skin to curl, muscle to contract, and there's differential movement of connective tissue and fat. So what we actually get in a bottle is not exactly the same as what you put in, because there are changes, and I can demonstrate some of those in a minute. The best time to ink is when you've removed it, because then if there is any shrinkage or contraction, we can see that area because there will be no ink there. So how do you ink? The best ink, there is commercially available ink, and it comes in all different colors. And you apply it with a Q-tip or a cotton bud, and the way to do it is to dry the tissue. Use a swab or a piece of paper towel, dry the tissue, and then apply the ink. Now, for some of them, you'll ink the whole surface. Don't ink the top of the skin, all the tissue from your surgical margin. If there's a particular area that you're interested in, use a different color. Now, you have all your choices of color. Some pathologists, there are some colors that pathologists don't like. Pink. Our stain is pink and blue. Please don't use pink. Blue is okay because the part that you're inking stains up pink, so it's a contrast. Dark greens are a bit of a problem. And if you are using a cautery as your scalpel, then that will distort tissue as well. So you want a contrasting color. So use your commercial ink. India ink is fine, or tattoo ink is the same kind of stuff. Tattoo ink works just fine. Once you have inked what you want with the colors, separate colors, and there's no point in putting one side yellow and one side blue, because when you close your surgical wound, both of those margins are the same. If it has to be recut, they're both the same. So, if there's an area you're worried about, different color, or put a suture in there. Don't staple it, please. Staples do not get cut with a knife. They damage the equipment. So use a suture. And then on your submission form say, I'm worried about the place where the suture is. Now, you've applied your ink, and it's kind of relaxing to do that. You know, it's kind of therapeutic. It's like painting. Then, let it dry. Let the ink dry. The times when the ink won't dry is if it's a very fatty tissue, and the ink doesn't dry very well. So you just let it sit there and let it dry. If it's not drying very well, and it's very fatty, you can get some vinegar, commercial vinegar, on a Q-tip and just rub that area with vinegar. Roll the vinegar over it. The vinegar will actually coagulate that tissue. So the common fixative is formalin, formaldehyde. Vinegar is a different kind of fixative, and it's something to use if that ink won't dry. Once it's dry, it goes in the formalin. So, you get very excited about a tumour and you stick it in a bottle, one of those little yellow top jars, and it fills the jar, and you say, well, I've got to have formalin in here, so you put 3 drops in, close it up, and ship it. That doesn't work. There should be 10 parts fluid, 1 part tissue. Now for most of the samples that's pretty easy because they're very small. But if it's any bigger than that, you really need 10 fluid, 1 tissue. If you've got a large sample that you want to send in, we had one here the other day, it was 7 kilograms. It's about this big. That's not going to fit into a yellow top jar. I haven't tried, but I'm pretty sure it won't go. What do you do with that? Well, there's a couple of things. If you're close enough, you can ship it as it is on ice. And it'll be good for 24 hours, as long as it's chilled. You need to discuss those kind of samples with the pathologist. Is there a particular area that you're worried about? Then sample it yourself and put it separately. If you have larger samples and you have access to a lot of formalin, then you can fix it and then put it into a sealed plastic bag, one of those really fancy Ziploc ones, and then in another Ziploc bag, because it can't leak. You can ship it fixed but not floating in fluid. And I've seen specimens come from across the other side of the country, from Vancouver, come across in a plastic bag already fixed. The outside fixed at least anyway. The inside's not going to fix in a big sample like that, but who cares what the inside looks like? It's the edges that you're interested in. And if it's something peculiar and you're not sure how to mark it, take a photograph of it, send a digital photograph with an arrow saying, this is where I'm interested. Now, well, yes?
Those large samples that you're going to fix and then put in a Ziploc bag, how long should they sit in the formalin for you?
If it's a really big one, check with the pathologist to see what you're interested in. If it's a leg, then perhaps it can be shipped as is, just chilled. 24 hours minimum, 48 is better, and then ship. Okay, reality check. You notice how I spelled check? Money. If you have a 1 centimetre mass in a human, okay, just bigger than a pea, and depending on where it is, that and the lymph node dissection that will go with it, say it's a breast mass, male or female, doesn't matter, then there will be that mass and a lymph node dissection. They take 30 sections for that sample. Reality, in veterinary medicine, each slide, depending on the lab, costs about $12. 30 by 12, I don't think so for most people. So what we do, cartoon diagram here. The blue is the tumour. This around the outside is your sample, and the margin is this outer layer here. We take one cut, the black line through the middle. This goes right through the centre. This gives you one lateral up here, a second lateral, and it gives you the deep margin. That's 3 of them. We then cut this other tissue at a tangent to that, at right angles to it. This gives us another lateral margin, and over here we get the other one. That is the 5 margins that Michelle was talking about. That's in a small mass. The bigger the mass, the more you want, the more it's going to cost. This is what we call standard sampling. And this will give a measurement of the distance of the neoplastic tissue to the margin. Each section is 4 microns. That's 250 in a millimetre. If you consider, they had people say, section the whole thing. We want it serially sectioned. Okay, a 1 centimetre mass, that's 2,500 sections at $12 a piece. Credit card first, please, and it better have a big limit. I want an American Express, because that's how much it costs. In the human world, they do that. The other thing is, the technologist at the lab trims the sample. The pathologist does not trim. Why not? The pathologist is expected to do, depending on the company, 50 to 70 cases a day. Do you know how many is a mammoth day for a medical human pathologist? Some of them can do 30 because they trim. Just imagine how much extra it would cost. What does it cost for a surgical pathology sample, biopsy sample? It's about $70, right? That's the lab cost. $70 to $80. Right? The way it is a high volume, low margin system. And the profit on each case, depending on the lab, you can never get straight answers. I was in charge of the lab here. I worked out how much it cost. The profit is about $15 a case. You take 2 slides, your profit's gone. 3 slides, they're doing it for love, and they may as well be paying you to send it in. Right? That is how tight the margins are, the profit margins are. So, minimum number of slides. Some companies, 1 slide, that's it. You want a second slide? They charge you a whole bunch more. Others have a deal where they have more slides for some cases, but the majority of them just 1. So here is a typical skin mass. This is the slide, and this is the way we like to do it. So let's have a little look here. Yeah, we'll deal with the warnings. And this one doesn't want to come up, so we're just going to do that. And there it is. So we'll just turn it upside down. Here is the cut right across. You'll notice here that this mass, hopefully they did cytology, recognized it was an epithelial tumor of skin, don't need a wide margin, very narrow. They took about 1 centimetre of skin at the side, and at the right here, a couple of millimetres. Down here, a couple of millimetres. For this kind of tumour, that's quite okay. This one was inked, so they were obviously interested in the margins. Let's have a look at the ink. Here's the ink there. Notice that there is basically no ink in here compared to there. So the margin would be reported across there. The changes happen because of differential contraction during fixation. There's no fascial plane here, and in fact I wouldn't mention fascial plane because this is the type of tumour where you don't need to do that because it is well circumscribed. It's got a nice distinct area around the outside and all is good. So that is the deep margin and two lateral margins. These pieces here were taken at right angles from that, so that we've got 4 laterals and 1 deep. That is the standard sample. You can see now why you need to mark the spot that you really want to look at, because we're taking a very thin slice. And unless we actually capture that part, unless we know to take that margin, it probably won't get done. And you need to put it on the submission form because that's what the technician looks at. If there's any kind of question, we can go back and trim some more. It stays informal and it's good there for years. We can go back and get some more. Or the pathologist can actually look at it, and that does happen. But that's the reality of surgical biopsy, surgical pathology. So, what can you expect on a pathology report then? The recommendation from a working group with the American College of Veterinary Pathologists is that every report should indicate what trimming method was used. If it is this radial trimming method, that's the standard method now, then if that's the method, it may not be reported, but that is the one that should be used. The second thing is the diagnosis, because that's what you're interested in, and there should be some indication of certainty of diagnosis. How certain are you? And so words are used like consistent with, when you're not sure. Most likely, or straight out diagnosis, you can go to the bank on it. There should be an indication of the grade. There are grading schemes for many neoplasms, and the grading scheme is usually 1, 2, 3. 1 being good, 3 being potentially malignant metastatic. If there's no grade, then there should be a reason why not. So if it is a tumour where there is a grading scheme and there's no grade, then there could be a reason why you can't grade it. It's a second cut, it's a reoccurrence, some reason like that. The grading schemes are based on first cut, first surgery. Usually, and it is standard procedure, every report of a neoplasm should have a mitotic rate on it. And the standard number is number of mitoses in 10 high power field. And that's based on the maximum number. The only caveat to that is that the lymphoma people don't do it that way. They do it in number per high power field. This gives us an indication of how proliferative the thing is. There are other indications of malignancy, and usually an isokaryosis, variation in nuclear size, is one of those. And when I look at reports, these are things I look for. The diagnosis and indication of certainty, and then I look for grading, I look for number of mitoses or the features that are used in that type of neoplasm to determine grade. Many of the grading schemes are based on mitotic rate, an isokaryosis, and amount of necrosis. Then there should be a separate section for margins. The margins should be listed in millimeters to the lateral and deep, and to the narrowest margin, not the biggest one, the narrowest one. Now sometimes, if you take very wide, like a 3 centimetre margin or a 5 centimetre margin, that's more than you can fit on one histological slide. So then you say, well, we've got 2 centimetres and there's no neoplastic tissue here at all. The biggest that you can fit is on a slide is about 2.5 to 3 centimetres. And a mention of a fascial plane, if it's appropriate. So, I will now pass it over.
Put these pictures in for us, but that's okay.
Do what you do.
So, I don't know about you guys, but I found it really enlightening when I actually learned how the pathology samples are evaluated, because I didn't really totally understand. And working with a lot of human surgeons and things like that, often they'll be like, well, you know, so if it's a clean margin, it's a clean margin. I don't know what you're worried about. And we have this whole, like, clean or clean but close, or, you know, this whole kind of vague, how do we interpret these and what do we do about it? And so, you know, what I think is important to understand is, as you saw in those images, there's some pretty big gaps of areas that are not being looked at all. And so we're getting an overall global picture of what's going on, but we're not looking at every single edge of every margin. And so the first thing I tell every client is that, to me, a clean margin is really going to be dependent on how did I feel about the surgery in general, not just my pathologic margin. And that a clean margin does not mean 100% chance it's not going to come back. It's kind of like anything in medicine. People are kind of starting to figure it out, but everyone wants a guarantee, right? They want a guarantee that if you do something and you get an answer, then that's it, they're done. And so I always warn people that there's still a possibility, even with a clean margin, that we could have a local recurrence. And to go along with that, I always decide based on how concerned I am as to how frequently I'll watch that incision. So it's never a bad idea, especially for the first year or two after you've done a surgery, when you're seeing those cases back for their annual exams or every 6 months exams, get into the habit of really looking at those incisions as part of your physical exam. You're probably doing it anyways. Maybe you want to do it every 3 months and just have them come in for a short visit. But really make sure you're still keeping an eye on things, and that's going to depend a lot on how you think things went with the surgery. Small cutaneous mass, lateral thorax, nice fascial plane, nice margins, you're really happy. Probably a lot less worried about that one than a sarcoma that was maybe a little bit narrow. They were clean margins, but it was a little close, and you're a bit more worried. So really important to keep those in mind. A clean margin essentially means there's no tumor cells at the margin. Then there's this whole, okay, so then what? Do we have to have no tumor cells for 5 millimeters? Do we have to have no tumor cells for a centimeter? 2 millimeters, how do we make these decisions? For me, generally, I'll look at it, and depending on the tumor type, depending on how aggressive it is, depending on my surgery, I will consider sometimes somewhere around 2 millimeters, potentially to be somewhere where I'm a little more worried. I'm going to start thinking, okay, maybe that margin's a little bit close for comfort. But again, these have to be things that you're interpreting. It's really not helpful for you to do the surgery and to ask your colleague to call about the margins. If there's any question, it's always better to have you kind of following up and saying, okay, what did I see in surgery and what am I thinking? Because that really makes a huge difference. Oh, there's another one. So what are we going to do about a dirty margin? So we get these results back, and the pathologist says these dirty margins, or, you know, maybe there's tumor cells close to the margins. We've got lots of options. Number one, if there's tumor cells close to the margins, sometimes I'll consider calling and saying, hey, can we recut that section? So, you know, looking at a couple more samples or more slides and saying, okay, there's still only tumor cells close but not on the margins. I'm going to be leaning towards that. I'm happier with my margin than, because we've now evaluated more portions. So instead of losing, you know, seeing at a 20th of that, we maybe can see a quarter of it or an eighth of it, and then we can be a little more happy, again, depending on what we saw. We have a lot of options if we get a dirty margin. One option is just wait and see. So depending on the tumor type, depending on how aggressive it is, depending on the owner, there's going to be a lot of cases where we're going to wait and see. You know, subcutaneous, low-grade mast cell tumors that have a zero mitotic index, they're not all going to come back, even if they were truly just shelled out. Some of them will, though. And so it's important to kind of consider what happens if it does come back. So sometimes we want to recut these early. As Dr. Foster said, one of the reasons for that with something like a sarcoma is if we give it time to form granulation tissue, it becomes hard to see what's residual tumor versus what's granulation tissue. In some cases, if it's in a bad location, even if the tumor comes back and it's fairly minimal, it still could be a lot harder to cut than if we go back right away and cut it without any gross disease there. A lot of times, I always tell owners if I'm recutting a scar, even if there was a dirty margin the first time, there's a very good chance I'm not going to see any neoplastic cells on my histo sample, and that makes me really happy. So if I go back and I recut that, and they don't actually see any residual neoplasia, that's okay. That's a good thing. You've now taken, hopefully, those few cells that have been left behind. You've hopefully removed those and not left that bed behind. Generally, again, recutting tends to get into this dicey area of you don't have a lot of room for error. And so don't be afraid to send those right away as well. If you do want to recut, lateral thorax, things like that, just remember a dirty margin, it doesn't matter which margin is dirty, the whole site is dirty. So you have to treat that whole site as a contaminated site. The thing is if you've had a seroma or something in that region, really anywhere that has had any sort of potential fluid or contact, any disruption, that's all contaminated. So you have to treat all of that. And so a lot of these, we want, again, imaging. We go back to it more and more. We can recut these, but if I have imaging to tell me exactly where I'm cutting, I can make a much more educated decision. Probably less morbidity for the dog because I'm not necessarily going to have to go as wide, but I'm also going to know what's disrupted and what looks abnormal. So really, really important to kind of keep that in mind. So recutting is an option if we need to, and sometimes recutting is just enough to get rid of what residual disease is there. But that deep margin and the lateral margins all have to be considered for that. Radiation is an option as well. So, in quite a few cases, we end up looking at it and saying, unfortunately now we don't have a recut option. Surgery is always our first choice. Of course, I say that I'm a surgeon. But the most definitive way to get a cure is to remove the disease. Radiation is going to kill cells, but it's not necessarily going to kill 100% of those cells, and it's not going to work 100% of the time. Surgery works 100% of the time, of course. Definitely not, but if we have the choice of removing those cells versus killing some of them off and leaving some of them to kind of straggle and potentially regrow, we're going to try and do surgery in those cases where we can. But definitely radiation is something we use more and more because unfortunately we end up with these scars that we don't have a surgical option anymore. So again, why it's really important to kind of have your plan from the beginning. And the other thing that may influence your decision is if that tumor is left in situ, is that going to influence the potential for more disease later? So a lot of these low-grade tumors, your low-grade soft tissue sarcomas, your low-grade mast cells, they are very low metastatic rate. They're generally not going to spread. They're more of a local disease problem. In those cases, if it comes back, I'm a little less worried that it's going to become a systemic problem versus something else that's potentially a more high-grade disease. If you have gross disease and you're giving chemo or trying to do adjunctive therapy in the face of gross disease, you're going to be less successful. So those cases, it's going to be more important that we're more aggressive about trying to get rid of that local disease as well. And that, whoops. All right. So that's it for us. I think overall, there's hopefully a fair number of points that we've come up with. I'm going to pass off things to our medical team now. They're going to give you a couple, just a case examples of, and talk a little bit about staging and sort of the importance of that. And then at the end, there's lots of time for questions. So hopefully people have brought cases, and if you have any questions, then we can go through things, or if you want to clarify anything we've talked about. Generally CT. So occasionally, the question is related to imaging. Most of the time we're relying on CT. Occasionally we can use ultrasound, especially for intra-abdominal disease, but most of the time we're talking about CT. And the big thing to keep in mind, and even when you're reading a lot of these papers in terms of what margins to take and things like that, a lot of times that's based on CT. And so you're not just looking at a tumor and saying, okay, I look at this tumor and I'm going to take this margin. When you're looking at CT and saying, okay, what's the extent of disease? How far do I go beyond that? And those two things can sometimes be significantly different.
So hi, everyone. So this is really just going to act more as an addendum to the sort of broad topic today of margins and clinical or surgical biopsy. But really for the purposes of completion, It's important, obviously, for our oncologic workup, the staging of our patients prior to undergoing these biopsy techniques and over our concerns of whatever the diagnosis might be. So really, staging itself is our ability to determine the extent of disease. So, we know there's a mass, we have a suspicion of neoplasia, and so subsequently, the first step, at least from our medical oncology perspective, is trying to determine the extent of disease. And obviously, a lot of our patients coming in too, we think of cancer for the most part as being a disease associated with age, sort of an aging population of these pets. And so it's not always about metastatic disease, although obviously that's our primary concern. At the same time, too, ruling out concurrent morbidities before these owners are undertaking, big surgical approaches or chemotherapy or radiation, investing all that time and money, emotion, and effort into treating this disease. So really what we're doing is we're trying to establish, local disease versus systemic. And subsequently, that question or the answer to that question is going to help act as a bit of a fork in the road as to which way we elect to proceed, whether aggressive local therapy through things like surgery plus or minus radiation, or if, it's actually warranting more the chemotherapy or systemic side of this. So, not to go into too great detail, typical oncologic workup, at least from a staging perspective, involves a minimum database, your complete blood count, your serum biochemical profile, your analysis. Again, not likely in most instances going to provide evidence of metastatic disease, but a good sort of global health perspective on the patient, especially if they are going to be undergoing anesthetic, big surgical procedures, making certain there's nothing else concurrent we should be addressing before going to some of these bigger interventions. Thoracic radiography, a big thing here would be including 3 views of the chest to really scrutinize the thorax for evidence of potential metastatic disease. So we all find those suspicious pulmonary nodules, or there's a lesion that we're uncertain of, and so having those other views to corroborate that, is that lesion on the right lateral also present on the VD? Those are what we use to differentiate a real lesion compared to something that might just be on the exterior of the dog, or a summative effect with other soft tissues in the body. If warranted, abdominal ultrasound. Again, a lot of times, especially when we talk about sarcomas or carcinomas, we're not necessarily always worried about metastatic lesions to the abdomen. A lot of times we're doing it to rule out concurrent morbidities, so making certain there's not a big, on your 9-year-old German Shepherd, there's not also a big splenic tumor that, regardless of the nasal mass or whatever else is going on, so that, 2-3 months down the road, all the interventions we've done somewhere else are not negated by the fact that we missed something in the abdomen. That being said, mast cell tumors are a certain percentage that will metastasize to places like lymphoid organs, the liver and spleen. So, that's part of our workup in those instances. And then a big thing, obviously, evaluating the local lymphatics through cytology. Our clinical pathologists are nice enough to look at 10 slides for the price of 1. Sorry, Rob. But so we have that ability to it's important, obviously, as and part of our workup to do that. And then, of course, advanced staging. So Michelle has talked a lot today about using advanced imaging for surgical planning purposes. So, mass evaluations to extent of local disease so that they can plan for surgery. We oftentimes or sometimes use it as well for our staging purposes, so a little bit more sensitive of a test. I can't tell you how many times in the last week we found pulmonary nodules using computed tomography compared to thoracic radiographs. It's not something we always do routinely, but it is often offered to our patients. As well as, CNS, they use other advanced imaging modalities like MRI, things like nuclear scintigraphy for our osteo patients, or bone scans as well. So ultimately, I think, the decision for the diagnostics oftentimes is based on our diagnosis, or at least our index of suspicion of what that diagnosis might be. So, what we're offering, or what we're more strongly recommending in terms of of our diagnoses before entering into the realm of surgery or radiation or chemotherapy. And at the same time, too, our clinical correlates. So, you know, we're making certain we aspirate those big lymph nodes if they're there. Patients with respiratory signs, obviously, thoracic radiographs become more important. Yeah. So I know that Jerome here has a...
All right, so just to finish with a clinical case, short clinical case to illustrate the benefits of the staging. Yeah, by the way, I apologize for my French accent. If you don't understand what I'm saying, which is frequent here sometimes, they don't understand a word I'm saying, don't hesitate to ask me to repeat. So here you have Macy, who was a 12 years old castrated male American Bulldog who was referred in October in the Animal Cancer Center for 2 carcinomas. One that was on the top of the head, cutaneous, roughly 2 centimeter, mobile, really not impressive. It could be anything, like a cyst, an adenoma, mast cell tumor, anything. And on cytology, it was called carcinoma. The other mass was subcutaneous and quite deeply fixed to the right scapula. And this mass, again, on cytology came back carcinoma, and both were suspicious for basal cell carcinoma, which is considered a low-grade malignancy that is not supposed to metastasize, spread, and just surgery with 1-2 centimeter margins max can be curative. But there was also a history of urinary tract infection in May that was successfully treated with antibiotics. The weird thing is here was the location of the scapula mass. And Dr. Foster, you can correct me if I'm wrong, but on this location, in the deep soft tissues fixed to the scapula, you shouldn't have a carcinoma. You shouldn't have epithelial tissue. So that raised the suspicion of maybe it was a metastasis. So that's why we recommended the staging, and this even if the dog was doing great. No concern, no weight loss, no digestive disorders, just the pain from the mass on the scapula. No. So we started with blood and urine test. Blood test was not really concerning. Some hyperproteinemia, but globulins were normal. Thrombocytosis, not very specific. And elevation of BUN that once again could be some gastrointestinal loss or maybe some mild dehydration. The urinalysis was unremarkable. We continued with chest x-rays, 3 views, and this was more rewarding. So here is the left lateral view, and as you can see, superimposed to the heart, here there was a soft tissue nodule that was pulmonary nodule, and that we confirmed on the dorsal, ventral dorsal view here in the right lung lobe. And interestingly, we did 3 views, so we were expecting to see the nodule on the right lateral view, and in fact, as you can not see, there was no nodule. And it should be around here, roughly, but it was not visible. So that highlights the interest of doing 3 views for the chest, because you can easily miss a nodule. We continued with abdominal ultrasound, and here again, quite rewarding. So if you see here, this is the liver, and here there were a couple of hyperechoic nodules, not very well defined, and the most concerning, the most worrisome was this one. But it's not very clearly visible here, but it had a target appearance with hyperechoic margin and hyperechoic center. So suspicious for neoplasia. then the bladder, and there were two masses in the bladder wall. First was at the apex here, and the other one more close to the urethra, to the trigone here, and both were once again suspicious for neoplastic masses. And finally, the prostate. If you remember, Macy was castrated and when he was young. And the prostate here was not very severely enlarged, but sufficient to be abnormal for a castrated male. As you can see here, it was like 2 centimeters. And more concerning, it was heterogeneous with mineralizations in there, as you can see here. So definitively abnormal. So we ended up offering cytologies because at this point we were suspecting urothelial carcinoma, either prostate or bladder or both. At this point the true primary origin was less important. But we wanted to confirm that, or the owner wanted to have the confirmation. So we did traumatic catheterization of bladder and prostate. Both came back consistent with transitional cell carcinoma. And we reaspirated the mass on the top of the head, on the scapula, and also the liver nodule. The pulmonary nodule was not accessible. And the 3 samples showed the same population of neoplastic transitional cells. So initially, this dog was referred for 2 carcinomas, but that were consistent on the cytology report with basal cell carcinomas that are not supposed to be really malignant, that are local diseases that we can cure quite easily. And we ended up with urothelial transitional cell carcinoma that had spread all over the body. So several key points from this case. First, importance of the location of the tumor that you have. Like here, the mass on the top of the head was cutaneous and could very likely be just a basal cell carcinoma. The one in the scapula, in the deep soft tissues or fixed to a bone, you shouldn't have an epithelial tumor. So you should suspect a metastasis and search for a primary tumor. Second, importance to do a complete staging because you can miss some informations. Importance to do 3 views for the chest X-rays. Sometimes it's tempting, especially if you have just a cutaneous carcinoma or even like a low-grade basal cell carcinoma, to do just one lateral view prior to anesthesia, just to be sure that there is no obvious heart disease, pulmonary disease. And here, if just the right lateral view had been done, we would have missed the pulmonary nodule. So that's important. And interestingly, the owner reported that the cutaneous mass on top of the head was noticed prior to the pain in the shoulder. So if the dog had been presented at that time just for the mass on top of the head, probably the subcutaneous mass would have been missed because really there was no bump palpable, obvious at least. And so with the cytology report consistent with the basal cell carcinoma, it would have been easy to just remove it surgically and leave the dog alone. And then we know it would have been a disaster. And it's also not infrequent, even if the primary tumor seems really benign, like let's say it's a mast cell tumor in cytology and the mass had been present for months or even a few years. And for sure, probably it has not spread like this one, and probably just the surgery is sufficient. But you have to remember that we deal with geriatric patients and that are prone to old age diseases and to develop also several unrelated tumors. And it's not infrequent that we stage a dog for a tumor and we find another tumor that may be worse. An example, last year, a dog that was referred for mast cell tumor in the perineal region, and the mass was really clinically behaving like a low grade. It had been present for months, really slowly growing, not bothering the dog, no swelling. Cytology was in favor of mast cell tumor. We could have recommended just to do the surgery, that's all. We recommended to do a complete staging. And on the abdominal ultrasound, there was an intestinal mass. We removed both. The mast cell tumor was indeed a low-grade mast cell tumor, complete excision, probably cured. The intestinal mass was an adenocarcinoma, probably not cured. So that illustrates the importance of a staging, and it's never wrong, even if the primary mass, the complaint is in favor of a benign tumor, to do a complete staging, because we can have unrelated tumors or even unrelated old age diseases. Yeah.
On this case, you said the urinalysis was unremarkable. Is it unusual to have an unremarkable UA with excisional cell carcinoma?
Not necessarily.
Do they generally not exfoliate much with the things if they're in the process of growing along?
The problem with the routine urinalysis is that they do not really, they spin for the sedimentation, but not as much as they should to try to detect the, if we suspect a transitional cell carcinoma, we tell them, and they really try to concentrate even more than during the routine analysis. So yes, it's not unusual to miss the transitional cells, and we can have also physiologically in normal dogs some kind of transitional cells in the urine. So if they are not really abnormal,
I guess I would just expect transitional cell carcinoma is so obvious in the bladder wall that we would expect to find the same cells on a routine way.
On a routine way, we have a hard time getting a commitment, I'd say, on a routine analysis, and there would be atypical epithelial cells and transitional epithelial cells. But just as Jerome said, then we'll request, if we have, we usually end up going the other way around, we'll do the ultrasound, we'll have a mass, and then we do their analysis for a cytoscan preparation specifically, just to see the content of those cells.
So is that a request that you can make then if you want to send a UA to the lab and you see something bladder wall and you think, I don't know, is that liquid cystitis? It's neoplasia. Is also the cytoscan?
So I can't comment if that would be routine everywhere, but it's certainly part of the diagnostic panel that we can request. And so it's meeting the urine for cytology specifically as opposed to routine urinalysis. And definitely no criticism of the laboratory technicians who are doing the urinalysis, but generally, correct me if I'm wrong again, that's the majority of the people who are looking at just a routine way, counting, the white cells, red cells, those types of things. But if you actually want an interpretation, then you just submit it for a cytology sample. So whoever you use, I guess I would encourage you to ask how best to test that.
Because otherwise they may see epithelial cells, but you could have normal epithelial cells within your like any sort of normal UA, right? And so it'll just get commented as epithelial rather than any sort of atypical or characteristics.
Do you want to define traumatic catheterization?
yeah, so in many cases, even if you centrifuge really much your sample, you don't have a diagnosis with a transitional cell carcinoma. So the next step is traumatic catheterization.
I prefer catheter-assisted biopsy.
Yeah. So you insert a catheter, urinary catheter, and you ultrasound guided. You're gonna traumatize the tumor. You go in there and you do like that, like a cytology, but with a catheter. And it's usually exfoliates enough that we have a diagnosis.
So it's the rigid polypropylene catheters with the suction attached to them.
Yeah.
And these things seem like a simple thing, but when you come out of the bladder, just make sure that you're maintaining suction. And then I usually will just cut the tip off the catheter and then squish it into the to that.
Yeah, we try to avoid cytology, like transabdominal, for the risk of seeding. So if we can avoid, we do like that. It's easy to perform and usually rewarding. Yeah.
So I'd like to thank our presenters for tonight. do you have maybe some questions or comments for the different speakers? So we're sort of getting there going as well.
Anybody have a case study they'd like to know?
If you take 100 13-year-old bulldogs that presented for a tumor and stage them, you find something else, compared to 100 13-year-old bulldogs not presented for a tumor, but you go through the staging process, would you find the same number of abnormalities in them, or would you find more the ones that present for tumors?
So I guess the question is, just to repeat it for everybody's purpose, if you took a population of geriatric dogs and staged, so with suspicion of tumor, a diagnosed tumor, and completely staged them, and then you took a sort of equivalent population of geriatric dogs without that suspicion or diagnosis of cancer, would you expect to find the same abnormalities? I mean, I guess from that perspective, yes, with the exception I wouldn't be as concerned about metastatic disease. So yeah, I mean, ultimately, with or without a diagnosis of cancer, these patients are susceptible to, you know, any other disease that we can speak of. The only, again, the absence of cancer, our staging then becomes null for metastatic disease and more for those concurrent morbidities like we were talking about. I don't know if there's...
Yeah, we also can mention the multiple endocrine neoplasia syndrome that has not been proven in dogs, I think, but that may happen. Like if you have a thyroid carcinoma, you may potentially have another endocrine tumor. In humans, that's the syndrome. So they screen to try to find an adrenal mass or potentially, I don't know, another endocrine tumor. We had our journal club had a recent paper on dogs with thymoma and a retrospective study, and that showed that as much as, I think it was up to 25% of dogs that had another neoplasia. So yes, we can have, in some cases, I don't know, maybe some tumors, some dogs with one tumor are predisposed to develop other tumors concurrently, but there is nothing really proven.
Any ongoing studies in chronic lymphoid leukemia taxonal?
What was the question?
These studies, I just wonder if there's any ongoing studies on chronic lymphoid leukemia.
Oh, specifically at OVC, I thought you meant sort of scientific way. I don't know if Dorothy can see anything.
Yeah, not that I'm aware of. Paul, do you know of anything?
No, the question was chronic lymphocytic leukemia cats, and we don't have any specific studies here. We have a number of studies which I give you some sheets, just more looking at dogs with lymphoma and things like that. So we're doing our standard of care here, but that could change, and that's why I guess the other thing on the sheets was our website that you could change to see if some things are fitting some of the criteria you've got as well.
We do have one person in particular who is interested in all leukemias, and anything that's referred is worked up completely, and samples are taken for just simply for database purposes. So this person is collecting as many cases as they can of all leukemias.
Dr. Weiser, a question?
So this is a question for the surgeon. You mentioned that in lymphoma sometimes find trials and other tumors.
Sure, yeah. So it's quite unusual. It's not, I wouldn't say the majority of times, but you can occasionally see, especially in some of the really big like labs and things like that, they can actually have a mast cell tumor would probably be the most common that we would see, and again, not commonly, but they can actually have a central tumor, and then they've got a fat deposit or a lipoma around it. So it is always really important to kind of keep that in mind. In a lot of cases with those, you can get into trouble, but in a lot of cases, even though fat's not technically a fascial plane or a true margin, if you're talking about a really tiny tumor and a very large amount of fat, you're generally probably okay because it's a subcutaneous mass. They're typically more low grade, but you do have to be a bit careful. It's the same with when I'm sampling, especially in a big fat dog. Whenever I sample something and it comes back as fat, if it doesn't totally fit, so if it's not truly soft fluctuant, kind of everything fit with what I would expect a lipoma to look like physically in terms of palpation, potentially imaging related depending on, so you could even ultrasound them. Sometimes you can see that there's just a difference. So you're not talking, we don't necessarily, can't say I very frequently CT a lipoma, although we do sometimes if they're in large, very, very large or in unusual places. But even just an ultrasound probe on there, sometimes you can see that there's just a difference in the echogenicity and that there's not just fat, but you can actually see there's something more solid. And so we do occasionally see those. It's always a good idea just to make sure that you kind of take a peek in the middle. So, and then I guess for those of you that aren't aware, I apologize for my phone, but we are live streaming and tweeting this event tonight. And so we're taking questions from our online audience as well, and just something for you to be aware of if you're not able to make it to some of the sessions in the future. The goal is to hopefully make those available to you online at the time of the event so that you can look for information and if you have questions. And so we just had a question relating to for staging or relating to surgery of how frequently we use advanced imaging. So advanced imaging, the majority of our cases are going to be CT. And so CT is a really great tool for me because it provides me with a lot of information about anatomy as well as what's going on with the tumor. And so, there's always, one of the frequent questions I get relates to, well, why not use MRI? I thought MRI was better for soft tissues. And that's a great question, but we find there's a number of reasons for me personally that I find CT is a much better tool. One of them being it's much faster. So to do an MRI of a large region, typically will take in the range of an hour to an hour and a half for that imaging to acquire the images. And so that's one thing, whereas our CT, in a lot of cases, we can get an image in 15 minutes or less. You can get a very large, good, detailed study in that period of time. And so that really makes a big difference for us. The other thing is with CT, we can get more information about anatomy. So from the perspective of evaluating something for looking at reformatting, so changing the angles to try and really understand what we're dealing with before we go into to do surgery, we can use CT quite nicely because it can help us. We can change our leveling and our windowing to look specifically at bone versus looking at soft tissues, and we can do all of that within the same program in the same study without too much additional time needed or even space. And so I would say for us, the majority of large subcutaneous masses or masses in areas where we're concerned about the potential implications of surgery, then we're using advanced imaging a fair amount. I would say probably half our cases at this point we'll have more advanced imaging for surgical planning. Personally, if I can have a thoracic CT in those cases where I'm concerned that the dog shouldn't have thoracic disease, so in cases where it's not necessarily a tumor like an osteosarcoma where we know at some point it's going to have pulmonary disease, that may or may not influence our decision to do the procedure that's more palliative. But if we're looking at more definitive curative intent procedures, it is useful information. We don't always CT the thorax though, so that's something we discuss with the owners and discuss the pros and cons of doing that. There is more cost and time associated with it, and so quite often we're still relying on thoracic radiographs. And one of the challenges at this point is just the literature and the support to tell us that specifically how does the information we get on thoracic CT change the outcomes, and so we can't provide as much information in terms of, okay, so if the dog has chest mets on CT that doesn't have chest mets on X-ray, what do we do with that information? How do we treat those animals? And that's always a challenge that we face, is kind of, we now have the ability to gather a lot of information, and I think it goes back to your question of how many dogs are we going to see? We're finding all of this information, and what do we do about it? When do we use that information and say, well, okay, now our treatment options are changing? Or when do we say, okay, well, we have this information, we're going to move forward, but we're going to keep this in mind and have that kind of moving forward. So really important things that we're dealing with fairly regularly, because a lot of information is not always a good thing.
Okay, another question up here? Oh, yeah.
Do you guys recommend diethyl injection for finding aspirate of mast cell tumor before doing it or after doing it?
So I think the question was diphenhydramine prior to treatment of mast cells, or prior to handling of mast cells. I generally do. I think in a lot of cases you probably don't need it, but it's one of those things that I personally think that the morbidity associated with it is so low, and the chances of having a reaction to the diphenhydramine is very low compared to the potential risk if the dog does have a reaction. We do have a study going on here right now looking at some of those factors in terms of the routes of administration, and so it'll be interesting to see what they find. But they're looking at even potentially giving Benadryl IV, which is something at this point we don't recommend. And I know everyone's learned that, and so I'm curious to see kind of how that may change the way that we treat things. Do you guys have any further comments?
No, I echo the same thing. Here at OVC, we do routinely give diphenhydramine before. But
The biggest challenge we veterinarians feel when we have any cases for the tumors coming to our clinics. When we started doing the baseline database, like blood work, urine, or the x-rays, half of the amount we already spent. Most of clients, they are very reluctant to do the baseline work. They say, this is the tumor. It shouldn't want there. So please take it off instead of doing cytology and punch biopsies or something on those lines before spending my $500-600 and then $200 to $300 on the baseline work. What do you think? I think I missed your comments on when removing mass, how much margins you probably would take it, whether it's a nasty mass or just a simple lipoma or something along those lines. What do you think? How much we would take it in case of that event? How much mass we should take? Like the margins, I mean.
Sure. So I think the question relates to sort of how to sell the pre-operative evaluation prior to just taking the mass off, and then also a question regarding kind of how to address those tumors and sort of what margins. I guess there's kind of two elements there. I think ultimately the first discussion obviously has to be surrounding, okay, what happens if this turns out to be something more aggressive? And I think if you've had that discussion and you're looking at it and you're saying, okay, I think this is probably benign, but what happens if it's not? I think we all can appreciate not everyone is going to consider referral. Not everyone is going to do anything if the tumor comes back. Sometimes we're lucky that they're just doing something because it's dragging on the ground and causing problems. And so, we see those cases all of the time, and we're not trying to say that those cases shouldn't be getting treated without spending $1,000 before we're treating them. I think the important thing, though, is very much informed consent of them understanding, okay, what do we think this is and what are our consequences? I guess my personal opinion on cytology is that that's something that generally, if you're doing it fairly regularly in your practice, you can be quite good at the basics. And so I think at minimum, that's something can be fairly inexpensive. I think you can choose however you'd like to bill for that, but in general, that's a fairly inexpensive test. And it can at least help to give you a little bit of a differential list. In terms of how much to take in margins, it's a really tough question. In general, my recommendation is if you're expecting a benign tumor, and you don't think that you have options in terms of having more diagnostics, then generally less is more, so that if it does turn out to be something more aggressive, you haven't done too much to disrupt the local tissues in the area so that a bigger surgery could be performed. Typically I recommend half a centimeter for a benign tumor and not a fascial plane. So if we're looking at trying to remove something benign, if it's more aggressive, that's not going to be enough. But the whole point is that you're getting an answer. So that's an excisional biopsy. That's not a therapeutic approach for something that's more aggressive, with the expectation that then if it is more aggressive, then a bigger surgery needs to be done. But the hope is we're talking then about having a 1 centimeter incision to have to deal with to make your 3 centimeter or your 2 centimeter or your 1 centimeter margin. That's a lot easier than if you've taken 2 centimeters, now you've suddenly got a 4 centimeter margin that you have to take a bigger surgery around, and sometimes that becomes not an option. And so, excuse me. And so the challenge is, of course, it's amazing how many times people say, I just want it off, I don't care, I'm not going to do anything about it. And then suddenly when they get that information, they want to be referred and they want to kind of be more aggressive at that point. And you can't, as long as I think you've had those discussions, that's life and that happens and people change their mind. But certainly I think it's just really important to kind of think about what are the consequences if I cut this with a narrow margin and it does turn it to be something aggressive, or what are my other options? Oh, back.
I actually have a whole bunch of questions, but I'm going to put them into one. I have a question about margins and fascial things. And you listed as one of your tumor sites as distal limbs. You were talking about that out. And the most recent tumor mass I've seen is older dog, massive, lumpy nodule at elbow. Walking normally, not particularly painful, but it's not dragging on the ground, but it's ugly. How do you decide when, if it was to come in, or if we do it when the leg has to be sacrificed?
That's a great question. We try obviously very hard to save the leg whenever possible, and often again those are somewhat owner-driven decisions. So the most likely thing, if I, without seeing it, but based on your description, if I had to guess in an older dog on an elbow that's been slow growing and not taking that long, it's probably a soft tissue sarcoma. It's probably low grade, but we don't know that at this point. But if we go based on kind of the stats of what's most likely, and so a low grade soft tissue sarcoma, generally, we say about a 5% chance of metastasis. So generally, these are locally aggressive tumors. They're not tumors that we're concerned about distant disease. And so in those cases, the challenge becomes, what are the owner's goals? And so sometimes the owner's goal is they want to get rid of the tumor and they want no chance that it's ever going to come back. And so in those cases, if we don't have a lot of space, we don't have a lot of skin, then sometimes we end up considering amputation because that's the only way that I can almost guarantee that it won't come back. So I'm never going to guarantee it because who knows? But in general, if we are taking a 3 centimeter margin beyond, if we're happy that we've kind of got a good margin of tissue beyond, the lymph node feels normal, there's not any other reason to expect that that's a more aggressive or a different type of tumor. I've done my cytology at least to kind of be suspicious, and ideally a biopsy, but at least a cytology that hopefully points towards a sarcoma. In those cases, every once in a while, the owner will kind of go with amputation. But that's kind of, for me, is more an owner-driven decision. I very rarely actually, especially on the more proximal aspect of the limb, find that I have to do an amputation. So we do have a lot of options there for reconstruction with skin flaps and things like that. And so there's a decent amount of skin coming from under the arm and on the lateral thorax that in a lot of cases we can actually plan to do an excision and actually then do a skin flap or something to close that area. We can't necessarily always get 3 centimeter margins, but we know in the majority of these cases less is okay. And if we can end up taking a bit less, and then we always prepare the owners, there's still a possibility that we do what we can, and we may not actually get a clean margin, but that's our goal, depending on what we see. But most of the time, we're talking kind of the base package of we want the leg off because we just want the tumor to go away, or the Cadillac of we really want to look at, we want to image the dog, figure out if there's any metastatic disease with our staging, and then what are our options from a surgery perspective in terms of can we get a deep margin on that and can we get a more definitive excision. On the flip side of that, there certainly are reports of kind of taking these with less aggressive margins, but then planning that they may come back in a year or two, but because they're fairly low growing and these are slow growing and they're old dogs, some of those cases will get lucky that they don't come back. Or on the final kind of aspect of things, if the owners are saying, well, we don't want to do a big surgery, but we want the best chance of preventing local recurrence, we'll do a much smaller surgery and follow with radiation. Excuse me. And so the big thing with that is we're talking anywhere from $15,000 to $2,000 worth of surgery to $10,000 worth of surgery plus radiation, right? And so that's a huge spectrum, and it ultimately depends on what are the owner's goals and what do they want to get out of it at the end. Sorry. Does that make sense?
Any other questions? So again, I was going to thank our speakers, and I was going to say, though, what we could do is take a break for what will just be the hall here. We could take you down to the Animal Cancer Center. We'll probably go 5 minutes away. It's like the Pathology building. So if we have a 15 to 20 minute tour, see the big star, which are our linear accelerated onboard imaging, our radiation unit, and then we get you back up here. So once again, I'd like to thank our people for speaking.